Before we start, I would like to thank our sponsors, without whom the conference would not be possible. So I would like to thank our diamond sponsor, the National Cancer Institute, our silver sponsor, Electra, Novartis, Takeda, and the Varian Medical Systems, and our bronze sponsors, the American Cancer Society, Beckman Coulter, the Braze Mayers Quibbs Foundation, Kefadis, and IGS.
Thank you. I trust that you all had a well-deserved break and are fresh for the last session of the day. The last session will be on the special interest pathology group. So without further ado, let me introduce you to the speaker, to the facilitators for this afternoon session, Mohenu Isidore Diomande and Olufumi Ogobonye will now take over from us. Thank you.
Well, thank you. Good afternoon, everybody. Welcome to the Pathology Special Interest Group session. We are going to start by introducing our speakers. I'm pleased to introduce Dr. Frédéric Penolorca. She is graduated as a medical specialist in pathology in 1993 and in oncology in 1995. She also received a PhD from the University Aix-Marseille, France, in cellular biology and microbiology. She is currently professor of pathology at the University of Clermont-Ferrand, CEO of the Comprehensive Regional Cancer Institute, Centre Jean Perrin, Clermont-Ferrand, in France, Deputy Director of the research team INSERM 1240, and Head of the Molecular Biology Platform at Centre Jean Perrin. She is also President of the Immuno-Oncology Group at Unicancer. She is a member of several pathology and oncology societies, including the European Society for Medical Oncology, the American Society of Clinical Oncology, the French Society of Pathology, the European Society of Pathology, and the French Sénologia Group. She has many areas of expertise, and we are very glad to receive her at this session. The second I'm pleased to present is Dr. Andrew Belizy. He is a clinical professor in the Department of Pathology in the University of Iowa in the US. Dr. Belizy completed undergraduate work in anthropology and science, pre-professional studies at the University of Notre Dame, and received his medical degree from Northwestern University. Following combined training in anatomic and clinical pathology at the University of Virginia. He completed a fellowship in gastrointestinal and liver pathology at the Ohio State University. After 2 years as a junior faculty at Brigham and Women's Hospital, he moved to Iowa in the fall of 2011. He is currently Director of Immunohistochemistry, GI Pathology, and the GI Pathology Fellowship at the University of Iowa. He is an active member of the United States and Canadian Academy of Pathology, the American Society of Clinical Pathology, and the College of American Pathologists, including serving as chair of the USCAP Stowell Orbison Award and the College of American Pathologists. So let Professor Ogumbi introduce the other two speakers.
Thank you. I'd like to introduce Dr. Barry McBarry very shortly. Dr. Barry is an anatomic pathologist, and he began his training in Ireland and then moved to the United States of America for pathology residency at the Brigham and Women's Hospital in Boston, where he also did fellowships in urologic pathology and medical renal pathology. He did a postgraduate fellowship in cancer biology at the Massachusetts Institute of Technology, MIT, and currently he's practicing urologic and medical renal pathology at the University of Utah Huntsman Cancer Center and the Arup Laboratories. Dr. Barry will be talking to us on the Gleason grading system shortly. Last but not least, I should introduce my co-facilitator, who will also be making a presentation. That's Professor Diomande, Mohenu Diomande, who is the Vice President for Africa at the IAP currently. He graduated from the Abidjan University Faculty of Medicine in 1986. Became a full professor of anatomical pathology, CAMES, in 1999. Between 2012 and 2014, he was associate professor at the Faculty of Medicine of Nice in France. His research fields of interest have been HIV infection and related diseases, Helicobacter pylori infection in gastric pathology and cancers. Dr. Bomande has been vice president of the International Academy of Pathology since 2008. Before that, he served as the president of the French-speaking African division of the Academy between 1999 and 2007. He's a fellow of the West African College of Physicians, where he's currently the chairman of the Faculty of Laboratory Medicine. He's also editor-in-chief of the Revue Africaine de Pathologie, which is a CAMES-recognized journal of anatomic pathologists. Previously, he had been Dean of Education and Research for the Medical Sciences in Abidjan. He had been president of the International Conference of Francophone Deans and Faculties of Medicine, president of the African Conference of Francophone Deans of Faculties of Medicine, CADMEF. Initially CIDMEF, then CADMEF. Head of Service of Anatomic Pathology at the University Teaching Hospital of Cocody, Abidjan, since 1996. He is also currently the director of the specialization program in anatomical pathology in Côte d'Ivoire. For this session, I may just add that each speaker has about 20-22 minutes to give a talk. At the end of the day, we would have a period of question and answer. However, just to say that the first speaker, Dr. Loka, has to leave shortly after our presentation. So we appreciate that after our presentation, we'll give about 5-10 minutes for questions that might arise before she leaves. After that, others will then give their presentations. When they complete, we will take questions from the remaining 3 presenters. Thank you.
Thank you. So I'm going to start. Can you see my screen?
Yes.
Okay. So without further moment, I will start. So first of all, thanks a lot for the invitation. I'm one of my specialties as a pathologist is breast cancer. So my talk will be on optimal pathology and biomarkers in breast cancer. This is my disclosure. And we will have a look at the early breast cancer and metastatic breast cancer because the biomarkers are not exactly the same. And I will focus part of my talk on the importance of tissue quality because it's really the prerequisite for any biomarker testing and any quality in biomarker testing. And then I will share some perspective with you. First of all, I really want to insist on the fact that priceless information is given by the pathologist, and those information will never be given by biomolecular testing. So this is about the diagnosis, the proper diagnosis of malignancy, the grading, but also some biomarkers, proteic biomarkers that can only be evaluated on tissue, like for instance, PDL1, if I take this example. So first of all, early breast cancer. So for early breast cancer, we use every day for our for the patient management in the multidisciplinary tumor board several parameters. First of all, the TNM parameters, so tumor size, nodes, and eventually sometimes metastasis, but it's not for the early. And we will have a great role in measuring properly the slide, evaluating micrometastasis in lymph nodes, but I'm not going to get into details today. And then we have other parameters that are taken into account for the aggressivity of the tumor, age, because usually the youngest a patient is, the aggressivity is higher for those patients in theory, because some tumor, even in young patients, are relatively indolent. And then other biomarkers of aggressivity like high grades, some histological subtypes. Then we will look at predictive biomarkers, ER, PR, HER2, the proliferation with Ki67 and mitotic index, vascular invasion, plus minus BRCA status, because today we have, in my country, we have access to PARP inhibitors in early breast cancer, and the tumor margin that are very important for the surgeons. So these are the parameters that are mandatory on the pathology form. And we really need to have that to be sure that the pathologist didn't forget anything about the pathology evaluation of the breast cancer. I want to insist on the fact that morphology and histopathology is very important in breast cancer, because we have some tumor types that have intrinsically an excellent prognosis. So some of them are ER-positive breast cancer, like the tubular carcinoma or the invasive cribriform carcinoma, or some kinds of mucinous. But we also have triple-negative breast cancer that have an excellent prognosis. And those triple-negative breast cancer with excellent prognosis will be the adenoid cystic carcinoma, the juvenile secretory carcinoma, the medullary carcinoma or medullary-like, that has very high grade, but a lot of lymphocytic infiltration, where we know that the prognosis is better, and usually those patients can harbor BRCA mutations. And we have the metaplastic carcinoma. So when the tumor is expressing a type of tumor that is not present in the breast, and usually they have a very poor prognosis in breast cancer, except one type that is the low-grade metaplastic carcinoma, or fibromatosis-like. And it's very important to recognize those subtypes. This is this one, because this subtype, the patient does not need chemotherapies. It's the same thing for adenoid cystic carcinoma, for instance. So it's very important to have this information. So we know also that tubular and cribriform carcinoma that are ER-positive breast cancer have an excellent prognosis. And the question today is, can we avoid endocrine therapy for those cancer? Because we know that they usually don't relapse if the local regional treatment is good. And then we have variants like rare variants of lobular carcinoma. Lobular carcinoma accounts for 10% of breast cancer. It's usually grade 2 breast cancer, but we have a variety around of those tumors that are very high grade, are very aggressive, and that can harbor up to 25% of HER2 amplification and overexpression. So it's very different from the lobular carcinoma classical one that is never HER2 positive, and those tumors have really to be recognized because they need aggressive treatment. Among the predictive biomarkers that we need to reflex in breast cancer, we have the hormone receptor and the HER2. Hormone receptor, it's immunohistochemistry. It's highly dependent on fixation. I will show you that in further slides. We have two different cutoffs. The international cutoff is 1%, and it was taken like that, saying that if the fixation is poor, at least 1% of tumor harboring nuclei positivity with hormone receptor will be considered as positive. In my country, in France, we use 10% because we consider that between 1 and 10%, the biology of the tumor is close to triple negative breast cancer, and this has been shown in many studies. Recently, the ASCO-CAP guidelines in 2020 has published new guidelines, and they recognize that estrogen receptor between 1 and 9% are rare, around 1 to 2% of breast cancer, but they probably behave like triple negative. So they now recognize a new category that is called the low positive, the hormone receptor low positive category of breast cancer. But as I said, in France, anyway, those cases are considered as hormone receptor negative. And what is important is that they shouldn't be treated only by hormonal treatment, and they should benefit from chemotherapy. So it's important to take that into account. Progesterone receptor is usually performed with estrogen receptor in early breast cancer because it gives information on the prognosis. A tumor that is ER positive, progesterone negative is usually more aggressive than a tumor with a positivity of progesterone receptor. HER2 breast cancer. So we think that we have an overestimation of the positivity of HER2 around the world. And at the beginning, it was expected to have around 20-25% of HER2 positive breast cancer. In fact, it's probably closer to 10 to 15% in my country. We know that it's higher in African patients, especially patients from the sub-Saharan area of Africa. It's usually more frequent in younger patients. It's extremely rare in Asia, where the patient have more ER positive, HER2 negative breast cancer than in other parts of the world. Of course, it's very important because we have targeted therapies. When we perform this immunohistochemistry, so we have different scoring system. The 3+, when we have an intense membrane staining, complete membrane staining in more than 10% of tumor cells, we consider those patients as HER2 positive. And when we have complete membrane staining or incomplete membrane staining that is intense, or complete membrane staining that is of a medium intensity, we have to perform in situ hybridization to confirm that we have or not an oncogene addiction if we have an amplification of HER2, as we can see here on this FISH test, where we have a lot of pink signals, more than 20%. So those patients are eligible to anti-HER2 therapy. So if I summarize those predictive biomarkers, so we have really to be very, 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 very careful to the quality of the sample. PGR and HER2 are excellent negative predictive factors, meaning that if they are negative, the patient will not respond to hormonal treatment or anti-HER2 therapy. But their positive predictive value is medium because only half of the patient with HER2 positive disease will respond to anti-HER2 therapy in the adjuvant or in the first line setting if they are metastatic, and they don't all respond to hormonal treatment. Some of the luminal breast cancer will benefit also from chemotherapy. So we have this new category, the low positive, where the effect of endocrine treatment alone is unknown based on the new GCO guidelines. And the HER2 low category, so the cases where we have an expression of HER2 without an amplification, so the 2+ non-amplified and the 1+, those patients could be in the future, maybe, we are not sure today, but could be potentially sensitive to new anti-HER2 therapies that are antibody drug conjugates like trastuzumab deruxtecan. So it will be a new challenge for the pathologist to identify those patients. Proliferation is also a biomarker that is very diffusely used. It's not really recommended in the guidelines because of the lack of reproducibility. So we use either mitotic count, but we use that for the grading, for the SBR grading modified by Elson and Ellis. But we also use proliferation to define what type of hormonal receptor breast cancer we have, aggressive or non-aggressive, hormonosensitive or more chemosensitive. So we use immunohistochemistry with Ki67 that is staining the nuclei that are into the cell cycle. So mitosis and after mitosis. And we know that the cutoff usually used is between 15 and 20%. We published recently in GNCI, because I'm part of this international group on Ki67. And we consider that the technique is extremely not standardized. It's extremely sensitive to fixation and to time to fixation. If we wait more than 1 hour before fixation, we will have a decrease in the mitotic count and in the cell cycle cells because they will enter into a quiescent stage. So we consider that for sure we can consider a tumor low Ki67 if it's under 5% of tumor cell staining and high Ki67 if it's above 30. Otherwise, it's an intermediate value. So if we have access to a molecular signature, it's typically the case where we can use these expensive tools, but we can use Oncotype DX or MammaPrint or EndoPredict or Procinia for those cases. And maybe in the future, we will have to use CD46 inhibitors like abemaciclib in the adjuvant setting, post-neoadjuvant or adjuvant for high stage ER positive or HER2 negative breast cancer. And recently, the FDA has listed abemaciclib, CD46 inhibitors in early stage breast cancer with Ki67 superior or equal to 20%. So we will see, we don't know what will be the position of the other agencies and if it will be available in different countries. Right now, it's not available in my country. So we use this proliferation to define what are the type of luminal breast cancer, so ER positive or HER2 negative breast cancer that can respond to hormonotherapy alone or who will benefit from hormonal treatment. Usually the HER2 positive group or the triple negative group, they are very proliferative. But in the hormone receptor positive group, we really have cases with low proliferation in blue or high proliferation in red. And we use Ki67 to define whether they are considered as surrogate luminal A, because luminal is molecular biology, but we can use immunohistochemistry to approach those gene expression, or luminal B if we have a high Ki67. And as I said, we have gene expression signatures for those ER positive or HER2 negative breast cancer. Usually, when we can have access, or if it's reimbursed, if the patient can pay for them, it's only for the ER positive or HER2 negative breast cancer, either P and 0, so no metastasis, or 1 to 3 lymph node metastasis with Oncotype DX, because it was the result of Eric Sponder trial. So those signatures are different. They can be performed on paraffin-embedded tissue. 2 of them, Oncotype and MammaPrint, you have to send them to US or to Netherlands. Prosigna and EndoPredict could be performed in an hospital facility. They all give you high risk, low risk, except for Prosigna, that is also giving intermediate risk. And Prosigna is also giving you the molecular subtype, luminal A, luminal B, or 2, or basal-like tumor. We have prospective evaluation for 2 signatures, for Oncotype and MammaPrint. And one of the most used around the world is the Oncotype DX, because now we have the data for the node positive category. And we know that we can use this signature to avoid chemotherapy in patients with a low, in menopausal patients with a low Oncotype DX signatures, less than 25, and with 1 to 3 positive lymph node. That is really important progress for those women. And it was so important that in the TNM 8th edition, they switched to TNM only based on tumor, lymph node, and metastasis for the staging, adding different parameters of biology, ER, PR, HER2, the tumor grade, and the risk, only the low risk, that can help for a de-escalation of the stage. So those tests may be used to avoid over-treatment. And for instance, a tumor up to 5 centimeters, N0, M0, ER positive or 2 negative, with a low risk signature, even if it's a grade 3, will have the same prognosis category as a PT1A or B, so less than 1 centimeter, N0, M0. So it's very important. It's only used for de-escalation, not for escalation. Now, with the 5 minutes I have left, I will move to metastatic breast cancer. When we have a patient with metastatic breast cancer, we first try to retest the patient on the metastatic, because we have now a lot of patients who received anti-HER2 therapy for the adjuvant setting, or that will have also hormonal treatment. So we can have a change, a switch between the primary tumor and the metastasis. And one of the questions is, if we have a loss in ER-PR or in HER2 at the metastatic stage, what are we going to do in terms of treatment? And I think it's important to note that you have 8% discordance for HER2, either gain or loss, and up to 20% discordance for ER, and 33% discordance for PGR, progesterone. And usually for hormonal receptor, it's a loss. So it can be heterogeneity, but it can be also that the clone that has metastasized is more aggressive and is triple negative. Then we have other biomarkers. Of course, it will depend whether we have or not access to the drug. So we have BRCA status, first of all, because in metastatic breast cancer, we have access to PARP inhibitors for any breast cancer that is BRCA mutated, except the HER2 positive breast cancer. They can be BRCA mutated, but they are not in the PARP inhibitors field of treatment, because they already have a lot of treatment. We also have PIK3CA mutation as biomarkers. It's only for the luminal breast cancer, so for the ER positive breast cancer. But we don't have access to this treatment in France. It's not reimbursed. So we were testing PIK3CA on the biopsy or on the primary tumor. Or on liquid biopsy, it was possible also, but we don't have access. The drug is not reimbursed in my country, so we have stopped looking at that. And immunotherapy, so until yesterday, we didn't have any immunotherapy available in France because the one we had at atezolizumab was no longer reimbursed, but now we have access to pembrolizumab. So for immunotherapy, we have a biomarker, it's PDL1. It's very important to use the antibody that was used in the clinical trials because we don't have the same scoring system, and it's very different if it was atezolizumab from Roche or pembrolizumab from Merck, because the antibodies and the scoring system are different. But altogether, it's around 40% of triple negative breast cancer that are PDL1 positive. It's important for the clinician to know that some metastatic sites like liver have lower PD-L1 expression. So it's sites that are not supposed to be biopsied if you can have access to another site for biopsy because of the immunocompetency of the liver. So it's important to know that. And how? So we have different antibodies, different scoring system, and it can be really complicated because of that. Because we have also other antibodies that are in laboratory developed tests that are less expensive. And this is why there is many reasons to consider non-FDA approved assay approach, logistical, financial, and because of tissue preservation. So it's really a problem because we know that the antibodies are not interchangeable. And because of that, we need to work really on the technique, and we need to know what drug is available and to adapt our testing and scoring system to the drug, to the immunotherapy that is available in the country. So it's really a dialogue with the oncologist. And I will finish with the other antibodies that are available right now by immunohistochemistry. So NTRK, it's not available in my country, the treatment except in clinical trials, but it's available in Europe and US. So screening by immunohistochemistry and confirmation by in situ hybridization or by FISH, it's extremely rare in breast cancer, less than 0.5%, and usually it's in secretory triple negative breast cancer, but we have NTRK inhibitors. HER2 low, as I mentioned before, for clinical trials. It's a lot of breast cancer, around half of the ER positive and of the triple negative breast cancer that have a very low expression by immunohistochemistry without gene amplification. And androgen receptor for triple negative cancer with a cutoff value of 10%, and the patient can be eligible to those treatment by antibody drug conjugates. So with that, I will finish my talk by saying that it's extremely important to have a tissue of very good quality to perform all those tests, because what we don't want is a poor fixation. So we need to have a sample that is fixed as early as possible, if possible 1 hour after the end of surgery. Over fixation, so if the sample stays in the fixative more than 2 or 3 days, it's less a problem because we can do pre-treatment. We can work by even for molecular biology, it's possible. But under fixation, we will have a destruction of the tissue. We will have a destruction of the antigenic sites. So it's completely different. And this is not only the responsibility of the pathologist, but also the responsibility of all the team who is collecting the sample, the surgeon, the radiologist, and we really need to work together to have the tissue for the best quality, because as you can see, for pathologists, we have a lot of biomarkers in breast cancer, and we cannot perform those biomarkers by immunohistochemistry or the biomarkers we look by molecular biology, like the molecular signatures, without a good tissue and a good fixation. So this is the messages I wanted to share with you today. And with that, I thank you very much for your attention.
Thank you, Dr. Penolorca.
Yeah.
I don't know if there are some questions from the studio.
Can we revert to the hosts? Do you have any questions, please, on your chat?
No.
No questions.
No?
Thank you.
Okay. All right, now I just asked Dr. Locke one question then. What's the standard of practice in your country with respect to handling breast biopsy tissue? Either excision biopsies or mastectomies?
So we have, I would say, for 90% of breast cancer, we have a pre-treatment biopsy. So this is called the strategic biopsy, because on this biopsy we will have the diagnosis. We can do ER, PR, HER2, and we know that we have a good correlation in general with the surgical specimen. Because the standard of care for early breast cancer for HER2 positive or triple negative is to perform neoadjuvant treatment. So we do all the biomarkers on the biopsy. And then we try to have as many conservative surgery as possible. Now we have a lot of plastic surgery for the patient with breast reconstruction. But we are now used to do more and more on smaller specimens, more and more biomarkers and prognostic predictive information on smaller specimens.
Yes, so how long does it take on average to you get the specimen in the laboratory?
I'm very lucky because the operating room is like 15 meters from my pathology lab. So we receive instantly the specimen. But I have specimens from other hospitals, and what we do for those specimens, we use vacuum system. So when they have the surgical specimen, they have a vacuum machine that is specific for pathology specimen, and with that they can send the specimen to us at without refrigeration, without fixation, and it at least for 48 hours, the specimen will still be okay, will still not be degraded. So it's something that could be useful because we have more and more small hospitals around us without pathologists, because we have a shortage of pathologists. I don't know if it's the case in your countries, but in France, it's half of the pathologists are going to retire within 5 years, and we are clearly lacking of pathologists in my country. And so we have more and more centralized lab, and we try to use those vacuum preservation systems for the surgical specimen.
All right, thank you.
Thank you.
I think any of the other presenters can ask questions if they're interested. Clearly. Before it goes away.
Yes.
I have a question.
Right.
Thank you for your presentation. I really enjoyed it. I'm the chair of the College of American Pathologists Immunohistochemistry Committee. So your statements around the importance of tissue handling, they're very close to my heart. One of the consternations that we're dealing with right now is the recent FDA approval of the CDK4/6 inhibitor.
It's a nightmare for us. We had a lot of discussion in the Ki67 group. We want to send a letter and to have discussion with FDA because we don't understand this statement at all.
Well, I would love to work on a letter with you.
Okay, so I can connect you with my group. Yes.
Yeah. The consternation relates to the fact that there are only 50 labs in the United States that have a DACO Omnis among 1,500 labs that perform immunohistochemistry. That being said, I was hoping you could tell me a little bit about your as Ki67 has multiple diagnostic, prognostic, and now predictive applications. were you routinely doing Ki-67 immunohistochemistry, and how were you doing it? Hotspot or whole slide, eyeball estimate, or whole slide imaging and digital image analysis? And what clone and platform do you use in your practice?
So I have tested all the techniques to evaluate, because part of the Ki-67 groups, we have evaluated all of them in biopsy surgical specimen. And what we do in my lab, so we do the Ki-67 on the biopsy usually, so it's quicker. That's the only good point. And we have a little device on our on the cell phone, and we count the cells, the positive cells, and we evaluate between 500 and 1,000, except if we see a bowling that we have like 2 or 3 positive cells, or at the opposite, but it's a very high one. So this is one point. When we are between, I would say 15 and 25 or 15 and 30, we review the case with another colleague, trying to work on that. Unfortunately, in France, image analysis is not reimbursed, so we have tools in the lab, because we have been participating to many studies, we cannot use it, and we cannot give a result with this kind of software, because it's not considered in France right now. My lab, for routine, I have a Ventana platform, but I have all the platforms, because we are a research lab, so I have a DACO, and I'm really considering using now my DACO platform for PDL1, because we have the authorization for pembrolizumab for PDL1 since yesterday. Yeah. So I'm not using routinely the PDL1 antibody 22C3, but maybe I'm going to do that in the future for the patients. And it will be the same for Ki-67, because I'm very worried about that. And we know that we don't have exactly the same cases, but we use it for breast, because it helps us to triage for molecular signature. And of course, we use it for endocrine. In my hospital, we have a lot of lung and a lot of endocrine tumors. We are specialized in endocrine tumors. So we do a lot of Ki-67 testing.
And the app on your phone, does that facilitate you doing manual counts of
yes,
yes,
it's a Ki-67 app. That was designed by our quality assurance French group. And I have one also from the international Ki-67 group, but that's why I always have my phone with me in the lab, and I have my microscope just by me, and I use that for counting.
Thank you very much.
But it's really a nightmare, because it's not standardized at all, and taking such decision on that, it's really problematic.
Well, I know your group has been working very hard for many years to try to standardize it, but I think that this FDA approval was a giant leap.
Yes, but I will be in contact with you and with people from the group. Yes.
Right. Great. Thank you.
Thank you.
Okay.
Thank you very much for an absolutely wonderful session. We have 2 questions for our panel. One of the question is, what is the role, or your opinion on the role of pre-surgical biopsy? And would you recommend ultrasound-guided biopsy?
As well, I think that now we can plan many of the strategic biomarkers for breast cancer from the biopsy. So I will recommend that, and those biopsies are usually with an optimal fixation, because it will be fixed directly by the radiologist. If you have younger women, it can be ultrasound guided, because the breast is dense, and the mammography are not suitable for those patients with dense breast. So it could be one of the possibility, yes.
Okay, wonderful. Thank you very much. We'll move on to our next question. What is the best fixative for cancer tissue? Is one of the questions that has been addressed. What do you think would be the best fixative for the cancer tissue?
10% buffered formalin, no discussion. I have performed back 20, 25 years ago for HER2 studies looking at different fixative, and it's buffered formalin. But you have to be sure that your formalin is properly buffered, and especially in Africa where you can have very high temperature, you can have a concentration of the formalin, and it will change completely the buffer, the concentration. So it has to be monitored constantly. It's not difficult. The technician can learn how to do that, but it's really something the technician need to be aware of and need to be trained to monitor.
Wonderful. Thank you very much for that answer. So we'll do the last question for this session, which is, what is your experience on the role of immunohistochemistry in core needle biopsy compared to excision biopsy?
So usually the correlation is excellent. It's higher than 90-95%. The only thing that is where we really go back to the surgical specimen and retest on the surgical specimen is when we have a discordance between genotype and phenotype. For instance, if we have on a biopsy a very well differentiated tumor with a lot of glands and grade 1, and that is ER negative, PR negative, we should retest that on the biopsy. So those cases, or if we see a very important heterogeneity, we will retest on the surgical specimen. Otherwise, we can really trust the biopsy. And as I said, it's optimal because of the fixation.
Okay. Me, you are muted.
Yes, thank you. Dr. Locker, on behalf of the SIG, would like to thank you for your presentation and for your excellent responses to the questions that arose. Obviously, you took on a very important subject matter that everybody is keen on. And I'm sure that many people will be reaching out to you subsequently for further.
And you can share my presentation if the audience wants, because there are more data on this presentation on the optimal fixation and things like that on the other slides. So it's no problem for me to share.
Thank you very much.
Thank you. So I'm sorry that I have to leave everyone, but I have another meeting in 10 minutes. Bye-bye. Have a nice session. And thank you so much for the invitation.
Thank you very much.
Bye-bye.
Bye.
Bye. Have a good day. So next will be Dr. Bueno Diomande. And I think, is your presentation ready, sir?
Yes, it is.
Okay, can you share your screen, please? And
we try to earn some time because the time is running.
Yeah, so, right. So, 20 minutes.
Thank you. I will talk about the challenges the pathologist is facing in sub-Saharan Africa for cancer management. We'll first talk about the challenges, then the role of anatomic pathology in cancer management, make a situation analysis in sub-Saharan Africa, and finish by some proposals. Anatomic pathology is a very important discipline in medical practice, but it is totally unknown by the public and undervalued by health authorities in our countries. So what is the challenge before examining the challenges. According to the dictionary Le Littré, a challenge is a provocative statement by which someone is told that he is judged to be incapable of doing something. So the objective of my talk will be to prove that anatomic pathology plays a crucial role in cancer management and to point out obstacles to overcome in sub-Saharan Africa. One of the main challenges, I think, is what I call a problem of identity. I don't know if in medical practice there's a discipline like anatomic pathology with so many names. You have anatomic pathology, anatomical pathology, anatomic and clinical pathology, morbid anatomy. So it seems like we don't really know who we are. Sometimes people wonder if we are physicians or not, if we are biologists or not. So the question is, what is anatomic pathology? Anatomic pathology is a medical discipline that studies the impact of disease on the body of a living or a deceased person. As Wagner have said, the pathologist is a physician using a microscope in the same way that the surgeon is a physician using a bisturi. So the pathologist will be at the center of the clinical practice. He will gather information with the tissue specimen coming from the clinician, the biologist, the radiologist, and look at the specimen on the microscope, under the microscope, make a diagnosis, and this diagnosis will serve for the treatment. But after the treatments, sometimes the pathologist will evaluate the outcome of this treatment. To achieve this goal, there are methods used in anatomic pathology. The first is cytology, that studies cells isolated from their natural context. Then you have histopathology, that studies tissue samples, biopsies, or surgical specimen. And you have autopsies on the deceased persons. Those tissue specimens will be processed through machines embedded in paraffin blocks, cut by microtomy, stained and examined under the microscope to give a microscopic image, which interpretation will allow the pathology to make a diagnosis of disease and especially of cancer. You can also use ancillary techniques like immunohistochemistry that will reveal antigens expressed by tumor cells. You can also use molecular techniques to see the molecular events leading to cancer and allowing to treat this cancer. So what role can it play in cancer management? The first role, I think, is a diagnostic role because it guides clinical decision depending on diagnostic criteria as histologic types, differentiation, invasion of tumors. It also has a prognostic role through the generation of predictive data of the outcome of cancer disease. This is done through grading, scoring of tumors, staging. Here you have the example of the ISO 2016 grading of prostate cancer. Or you also know the classification, the Nottingham classification for breast cancer in 3 grades. Anatomy pathology also plays a theranostic role when it determines phenotypic and molecular features leading to the choice of targeted therapies. That is the example of B cells lymphoma expressing antibody CD20 treated by rituximab, gastrointestinal stromal tumors, and anti-CD117 treated by imatinib, breast HER2 plus cancer treated by trastuzumab. Anatomy pathology can also precise the status of RAS gene that will allow good, very accurate treatment. Anatomy pathology also has an epidemiologic role by generating accurate data for political decision making. That are the frequency or prevalence of cancers, histologic types, age and sex distribution of tumors. And also, you all know the cancer registries in which the anatomy pathological diagnosis is very important. Cancer screening, breast, uterine cervix, or prostate. It also plays a research role through the collection, classification, and conservation of cells and tissues for translational research, biobanking, use of blogs, databases in pathology labs. What is the situation in sub-Saharan Africa? The situation in sub-Saharan Africa is what I call a paradox. That is exemplified here by this image. WHO has said that 25% of all deaths in Africa will be related to non-communicable disease by 2015 with infant cancer. But we see there's a lack of infrastructure to develop and maintain equipment and scale up the demand in pathology services. There's a huge shortage of personnel. When you see that, you look at this map, South Africa, that has the most important number of pathologists, has one pathologist for 200,000 to 500,000 people, while in the UK, for instance, you have one pathologist for 15,000 people. There's a low level of performance of pathology services with lack of procedures for quality assurance and quality control, long turnaround times, suboptimal diagnosis due to recurrent lack of reagents, obsolete equipment, and so on. When you look at the structure of the health pyramid, most of the pathology labs are in the UTH or institute. There's no activity at a regional or first contact place. Is there place for hope despite all those problems? I think yes. So I think it's possible to reinforce the health system through, for instance, the promotion of cytopathology at level 2 of the health pyramid, promote autopsy practice, because autopsy practice is very important to understand how cancer behave in patients. Neutralize resources. For instance, creation of regional technological platform, like the one in my country, Côte d'Ivoire, train specialists and technicians in sufficient number, promote endogenous research to guide health policies, rationalize behaviors and costs by setting up standards of good and best practices, quality assurance, and accreditation, make tumor boards mandatory in oncology, advocate for anatomy pathology at national, regional, and international level through, for instance, the promotion of public-private partnerships, develop partnership with anatomic pathology organization. For instance, International Academy of Pathology, USCAP, the divisions of the academy, and so on. There's a need to invest in anatomic pathology services because as we all know, health is priceless, but it has a cost, and someone has to pay for that. Our countries have made a lot of declarations, one in Abuja in 2001 to allocate 15% of national budget to health, in Maputo in 2003 to integrate in national health development plans, a strategic plan to develop laboratory. The question now is, where are we? And an answer is that, unfortunately, this target had been achieved only by 5 countries by 2010. And during the same period, 13 countries have reduced their relative government allocation to health. I'm not sure the situation has changed so far. So my last question will be, what if we engage ourselves in politics as pathologists? Because in Africa, most of the time, when you are in politics, you are able to take decisions to develop some projects, and that will be help anatomy pathology to be the center of cancer management. Thank you.
Yeah, so thank you very much, Dr. Diomande. And you did that in good time so that we have enough time maybe at the end to tackle many more questions than I was anticipating.
No, I think we have to listen to the other.
Listen to the other people.
And make a group discussion at the end.
Yeah. So I think the next person will be Dr. Felici.
Good afternoon, everybody. Thank you for the opportunity to address this august audience. And I'm going to talk about the pathology of colon cancer, perspectives on colon cancer in Africa from here in Iowa City. I have nothing to disclose. As was mentioned in the introduction, I'm a GI pathologist and I'm a diagnostic immunohistochemist, and I am so locally, but I also serve in these roles nationally as well. The thesis for the talk is that, and I think this resonates with the last talk, is that cancer care is best delivered by specialists working in multidisciplinary teams. Can't emphasize enough the value of the tumor board, that CRC, colorectal cancer, is increasing in incidence in Africa. It's a problem. We have finite resources at our disposal. Policy can be made and resources can be allocated nationally, but decisions how to specifically deploy care need to be made locally in the context of what can be done at a certain geography. And I think the point that should come across from all these talks is that every patient deserves a pathologist. And I think all the panelists are committed to encouraging improved infrastructure and increased training for pathology in Africa. So around improving pathology in low and middle income countries, every patient deserves a pathologist. When I was a junior faculty at Brigham and Women's Hospital back 12, 13 years ago, I worked as part of a team that saw specimens from Haiti and from Rwanda through this Partners in Health model, where specimens were obtained locally. They were shipped to Brigham. They were processed. The slides were made, and they were distributed to the sign out of the workaday pathologists like me. And I know this Partners in Health has also worked to establish and improve infrastructure in hospitals in Malawi, and I would say, you know, more of that, and I'd like to know what I can do to help with more of that. This paper that the group wrote also pointed out this group, Pathologists Overseas, and this is a shot from their website that's really committed to not outsourcing the pathology to the States or to Europe, but to building up the skills and infrastructure of the local pathologists. I came across this paper that took another look at improving AP practice in sub-Saharan Africa. And here we had groups of US-based and sub-Saharan Africa-based pathologists teaming together to give lectures and do case-based learning at a teaching center in Kenya. Outlined for the talk, I'm going to talk about the epidemiology of colon cancer around the world and contrast it to what's happening in sub-Saharan Africa. Talk about the treatment of colon cancer, what's generally recommended, depending on the PTNM stage of the disease, and then what might actually happen at a regional hospital. Talk about screening for colon cancer, colonoscopy. Briefly discuss the molecular pathology of colon cancer, and spend some time on pathology pain points. These are things that non-GI subspecialists struggle with in diagnosis, and things that are critical to diagnosis and prognostication in colon cancer. As far as the epidemiology of colon cancer, like many diseases and many cancers, there's incredible variation in frequency depending on where you live in the world. Overall, colon cancer is the third most common cancer and fourth most lethal cancer in the world. It's generally related to Western lifestyle, has a 5-year survival of 65% in high-income countries, and typically the median age at diagnosis is 70 years of age. Historically, colon cancer in Africa was quite rare. I found a report from 1964 from a hospital in Tanzania where 2 cases of colon cancer were diagnosed over a 10-year period. But this epidemiologic data over the last 20 years, from 2002 to 2018, shows a steady increase in the incidence of colon cancer in Africa, approaching, especially in Northern Africa and in South Africa, approaching rates in the West. So it's now the 5th most common cancer in sub-Saharan Africa, but there are very distinct clinical epidemiologic characteristics. 20 to 40% of patients present at less than 40 years among the indigenous population, and that's in stark contrast to 7% of cancers presenting in folks under 40 years in high-income countries. There's a very high frequency of rectal cancer, as opposed to cancer involving the remainder of the colon. Unfortunately, there's a very high frequency of stage 4 disease, about half of patients present with distant metastasis, which is incurable and can only be palliated. This report that described cancer at a hospital in rural Kenya said that no cases in institutional memory had been discovered in the context of colonoscopic screening. Patients are presenting with symptomatic cancer, and patients who present with symptomatic cancer present with higher stage disease. And this hospital in rural Kenya had no pathology practice on site and had to refer to that top of the pyramid that Dr. Diamond had described for pathology service, which resulted in significant delays in pathology diagnosis. This increased frequency of colon cancer in Africa over the last 20 years especially has been attributed to westernization of diet and an emerging obesity epidemic. Standard treatment for colon cancer, again, every patient deserves a pathologist. The pathology determines everything in terms of prognosis and therapy. We've got stage 1, 2, 3, and 4 disease. Patients with stage 1 disease have limited local disease without nodal or distant metastasis, and they're treated by surgical excision, and in special cases can be managed with polypectomy alone. We've got patients with stage 2 disease who have more locally advanced disease, PT3 or 4, without nodal disease or distant mets. Those patients are treated with surgical excision, and in high-risk patients, and we'll talk more about high-risk stage 2 patients in a bit, there's consideration of adjuvant chemotherapy. Patients with rectal cancer that present at PT3 or 4 are treated with neoadjuvant chemoradiotherapy. Stage 3 disease is defined as any PT with nodal disease and no distant metastasis. Those patients are resected and are given adjuvant chemotherapy with intent to cure. Patients presenting with clinically nodal disease in the rectum are again treated with neoadjuvant chemoradiotherapy. And patients with stage 4 disease are generally incurable. These are patients who present with distant metastasis, and they ideally receive chemotherapy with intent to palliate, to improve quality of life and to prolong life. I found a report of what's actually happening. So this is a report from 5 Nigerian cancer centers, 300 consecutive colon cancers diagnosed over a 4-year period. And they demonstrated a lot of the epidemiologic findings that have been described in cancer in sub-Saharan Africa, namely an enrichment in rectal cancer, which has special problems. More than half of patients presented with stage 4 disease. The majority of patients were able to get the surgery that was recommended, but just over half were able to get chemo, and a very small number were able to get radiation therapy if recommended, speaking to the lack of infrastructure to deliver radiation. For those that declined the recommended surgery or chemotherapy, 1/3 cited financial reasons and 1/3 cited personal reasons. So there's substantial obstacles, especially financial, to the delivery of this optimal care to colon cancer patients. That being said, there's a substantial benefit to patients getting the recommended therapy. In this cohort of 300 patients, the median survival in patients who got the recommended course of therapy was 2 years, and the median survival in those who declined was only 8 months. So on to screening for colon cancer. So especially in high incidence regions, because colon cancer has a very long preclinical phase and has an identifiable treatable precursor, the colon polyp. And because when patients present with manifest cancer, the treatment costs are so high and the morbidity and mortality is so significant. In many regions of the world, screening for colon cancer is a no-brainer. There's an argument in developing countries whether this investment is worthwhile. And there's these two famous papers that address this issue in developing countries. There's this one from Lambert that takes this qualitative approach and says, in developing countries, there's a relatively low burden of disease, and the burden of communicable disease is great. Resources are finite, again, and they advocate against screening. But there's in contrast, there's this quantitative economic analysis that was done by Ginsberg and colleagues that did mathematical modeling and looked at multiple different screening and treatment interventions in breast, cervical, and colon cancer and ranked them from least or most to least cost effective. And down here at colon cancer, they found especially treating colon cancer according to recommendation, chemotherapy in stage 3 disease, surgery in stage 1, 2, and 3 disease was actually highly cost effective, and that even screening colonoscopy was cost effective in sub-Saharan Africa. The molecular pathology of colon cancer is actually long well defined because of the adenoma carcinoma sequence, the ability to do molecular genetics on the precursor and on progressive stages of disease so as to be able to define a sequence of events. That being said, it's been more formally done in the last 10 years. It was studied as a TCGA, and there were no surprises. All the things that we knew about the molecular genetics of colon cancer, that there was a chromosomal unstable and a aneuploid pathway that represented about 85% of cancers, and an MSI high or hypermutable pathway that represented about 15% of cancers, and activation of Wnt signaling and TGF-beta signaling and PI3K signaling and RAF-RAS signaling and P53 abnormalities were recognized. Of all the molecular genetic events in colon cancer and actually pan cancer, the biggest game changer in the last 5 years has been the recognition that MSI high tumors that are characterized by deficient DNA mismatch repair, which can be detected by molecular or immunohistochemical methods, are highly responsive to checkpoint inhibitor therapy, which Dr. Lorca discussed in the context of triple negative breast cancer, things like pembrolizumab and atezolizumab. This first paper showed that in MSI high cancers, independent of the tumor diagnosis, that 50% of patients responded, and 21% of patients with metastatic colon cancer can actually achieve a complete radiographic response. And metastatic colon cancer that was uncurable, and this significant fraction of patients is almost curable, or at least curable for years and years and years, given the high efficacy of checkpoint inhibitor therapy in this molecular subtype of colon cancer. Aside from MSI, the molecular pathology of colon cancer has been fairly static. This is a biomarker template from the College of American Pathologists that I recently participated in the updating of, and it hadn't been updated in 7 years, speaking to, aside from the recognition of the significance of MSI vis-a-vis checkpoint inhibitor therapy, not much has changed around the molecular genetics of colon cancer. So I was especially interested in the frequency of MSI high in sub-Saharan Africa, given the potential home run of checkpoint inhibitor therapy in this class of tumors. And I had seen this paper several years ago out of Ghana that showed a very, very high rate of MSI high in their patient population at 41%, which is much higher than the 15 to 20% typically encountered in the West. And this was seen in a second study from Nigeria and a third study, a second study from Nigeria published a few months ago. But this result seems to not be reproducible from local population to local populations. We've got studies in South Africa, Zimbabwe, and the Ivory Coast where the frequency of MSI high is much more similar to that seen in the West, around 10 to 15%. This is the reflex GI biomarker testing that we do at Iowa, also that's done at Memorial Sloan Kettering. And I'll just take our attention here to colon cancer. Because of the importance of this MSI phenotype, we've been testing all colon cancers with immunohistochemistry for DNA mismatch repair for about 10 years. We also do BRAF, all RAS mutation testing in metastatic colon cancer. Immunohistochemistry is really difficult. So this is a panel of DNA mismatch repair immunohistochemistry. We interrogate these four enzymes, MLH1, PMS2, MSH2, and MSH6. And this was actually interpreted by the outside pathologist, and it was their outside assay as intact, normally expressed DNA mismatch repair proteins. But these patterns in the MLH1 and PMS2 stains were peculiar, and we repeated the staining in my lab with our assays and our clones and our instrumentation, and we achieved a very different result with clear-cut loss of MLH1 and PMS2. And it comes down to, the devil is in the details. It comes down to the clones. So there's this clone M1 and clone A16-4 for MLH1 and PMS2 that are problematic, and we use different clones in my lab. And these artifacts are well described. That being said, this assay, the bad assay, is FDA approved, despite the fact that there's these case reports that show that these clones, M1 and A16-4, perform poorly, and EQA or proficiency testing data from Scandinavia that show the same. BRAF V600E mutation-specific immunohistochemistry is also problematic. It's expensive, and labs in CAP proficiency testing, particularly in colon cancer, struggle to identify true positive cases. Every time I give a talk, I learn something new, and I'm very excited about a technological leap. A molecular platform called IDILA that is incredibly user-friendly and relatively cost-effective, where you can just scrape the tissue section directly onto a piece of filter paper, load it in a cartridge, stick it at a machine, and 2.5 hours later, it spits out the result. And I'm very optimistic that this technology will democratize access to molecular testing. This is their current test menu. And these assays have been extensively validated compared to gold standard and have performed incredibly well with very low rates of technical failure. And they're relatively inexpensive. They're about half as expensive as traditional NGS-based methods. I'll wrap up with the pathology pain points or the threats and opportunities. One thing that can't be emphasized enough is the importance of using templated-based reporting or synoptic reporting that ensures the completeness of reporting compared to traditional narrative-based reporting. I mentioned a special stage 1 colon cancer, cancer in a polyp, where it's a very small cancer arising in a endoscopically removed polyp. And in that special circumstance, polypectomy is sufficient. Patient doesn't have to undergo a segmental resection. If all these criteria are met, tumor must be low grade, lymph-vascular space invasion must not be present, the stalk margin, the base of the resection must be negative, there must be low grade or no tumor budding, the polyp should be pedunculated, and it must be removed in one piece. That being said, pathology reports from these very important specimens are often incomplete for all these data elements, again, suggesting the importance of template-based synoptic reporting. Tumor budding is the H&E manifestation of the epithelial to mesenchymal transition in colon cancer. And this is a just recognized and described about a decade to 15 years ago, but has really gained momentum in the last few years and has been widely adopted in clinical practice through incorporation into the CAP cancer protocols. So here's a colon cancer, and there's something squirrely going on at the leading edge here. And at the leading edge, the tumor is breaking down into single cells and small groups of cells. Single cells and clusters up to 4 are referred to as tumor buds. And not all tumors show this phenotype. Here's another colon cancer that has 0 tumor buds. And this white paper here, this very important resource, gives a step-by-step procedure for enumerating, for counting tumor buds. And this is an essential component of the pathology report and something that we've incorporated into our practice over the last 5 years or so. Age-old question, lymph node recovery. How many lymph nodes need to be retrieved from the specimen? Different groups give different recommendations. More is better, but generally at least 12 or 13 lymph nodes should be retrieved, removed, pathologically examined. My practice, when fewer lymph nodes are retrieved, is to go back to the specimen, submit more lymph node candidates. And here's an example of a case where at first pass, we identified 8 negative lymph nodes, but on the second pass, we identified 7 or 10 more, and 1 contained this lymph node metastasis. And this is a game changer. This takes a stage 2 patient and makes them stage 3. Stage 2 patients don't clearly get chemotherapy. A stage 3 patient's gonna get the chemotherapy that they deserve, from which they're statistically likely to derive substantial survival benefit. TME and neoadjuvant treatment in rectal cancer. So rectal cancer is special. Rectal cancer is hard. It's difficult. It's difficult to do the surgery. It's difficult to evaluate the specimen. It's important in sub-Saharan Africa because rectal cancer is enriched in the sub-Saharan patient population. About half of your colon cancers are going to be rectal cancers. So the TME is this very special surgery, best performed by folks that are highly trained in it and do at least 50 or so cases a year. And that procedure that's been adopted the last 20 years or so has taken local recurrence rates from 30 to 40% down to the 5 to 15% range. And the addition of neoadjuvant before the surgery, chemoradiotherapy, has led to even further reduction in local recurrence rates. I'll point you to the.
Okay, sure. Thanks.
I've got 3 or 4 more slides. Is that okay?
Yeah, we're going to buy into this discussion time.
Okay, I'm happy to wrap it up.
Okay.
We can defer to discussion. And in the discussion, we can talk about grossing of rectal cancer. We can talk about the distinction of T3 from T4. We can talk about tumor deposits. And we can talk about triaging of patients with stage 2 colon cancer who don't obviously as a whole group benefit from chemotherapy, but that probably do in select circumstances. And there are clinical and pathologic criteria that select patients that we use in multidisciplinary tumor board to select patients for the therapy. And that's all I have. Thank you.
Thank you. I have a feeling, I have a sneaky feeling that you might be able to deal with this because these are very important things. But I think we should give the opportunity to Dr.
I agree.
Barry to do his presentation, and then we can spend the rest of the time on this. Thank you very much.
Oh, thank you.
That's very lucid presentation. Clearly, it's been a well-discussed topic, but I think we should move on to Dr. Barry, and then we would come and talk about every other thing. Thank you.
Okay. So today we're going to talk about the Gleason scoring system, Gleason grade group system, and prognosis in prostate cancer, and that will include the higher grade, the higher grades as well. So I don't have any disclosure to make. So prostate cancer is very common. It's a big problem. It's the second most common cancer in men worldwide, and it's the leading cancer cause of cancer and cancer-related deaths in men in sub-Saharan Africa. In terms of men of African descent or African origin are disproportionately affected by prostate cancer. So some points are that in the US, African-American men have the highest incidence of prostate cancer among all men. In Afro-Caribbean men have the highest prostate cancer mortality. And in sub-Saharan Africa, the tumor grade and stage are highest in men found from sub-Saharan Africa. So it's prostate cancer is also on the increase in Africa. Let me just show you some data, a slide from a recent paper based on the Africa Cancer Registry Network, which I think samples 12 sites from 11 particular regions in sub-Saharan Africa, and you can see some of these represented here. And so what we're looking at here are age-specific incidence rates by year. I think what you can see is that in all of these particular areas, prostate cancer incidence is on the increase, highest in the Seychelles and the Eastern Cape of South Africa, but it's increasing across the board in these areas. Just to put some other numbers on this, in terms of lifetime risk of cancer, in this paper, it was noted that the highest lifetime risk in sub-Saharan Africa and Seychelles were 1 in 9 men will develop prostate cancer during their lifetime, followed by Harare, Zimbabwe, where 1 in 10 men will develop prostate cancer in their lifetime. So, you know, a lot of things obviously need to happen here. A lot of things in terms of the clinical setting with increased detection, advances in the use of the novel therapies that we have now. But what can we do as pathologists is what obviously we're going to focus on today. And grading is a particularly important component, especially in prostate cancer. So ideally, a grading system is going to give you an idea of the biology of the tumor. It's going to mirror the biology of the tumor. It's going to give you an idea of the prognosis if it were untreated, but also prediction of response to therapy or ability to guide therapies in that case. It should have concordance, give you an idea of the biopsy grade, should ideally have good concordance with what the true tumor grade, i.e. what you would find on the resection, would have. And also from a practical purpose, a practical side of things, it should have good pathologist inter-observer concordance. If there isn't good concordance, the grading system isn't very useful. So there have been many grading systems in the past in prostate cancers. Some of them even have included cytologic features, but really the Gleason system is the system that's won out over the years and is the current sort of worldwide standard. It's over 50 years. We've had it for over 50 years. It's hard to believe. You know, one of the things that from Dr. Diamond and Dr. Belisi's talk that has come across is the issue of resources. But let me stress, you know, Gleason grading is based only on the H&E. Don't get me wrong, there are molecular advances in prostate cancer, in particular, advanced lethal prostate cancer and association with germline DNA damage repair mutations and their response to PARP inhibitors. But that's not what we're talking about today. We're talking about the most powerful prognostic that we have in prostate cancer, and it's based on the H&E. So even if resources are limited, everybody can do a really good job of giving this information for the treatment of the patients. There's some unique features of the Gleason system. If you think about grading of most of the other tumors that you can think of, it really factors in aspects of architecture, but also aspects of cytology. The Gleason does not. It's architecture only, the patterns. The other unusual feature of the Gleason system is that we give a sum of two patterns. Typically in grading schemes, you give the worst, or the cytology, you give the worst area. But in Gleason, you give two patterns, and the order matters. So 3 + 4 is not the same as 4 + 3. That carries prognostic information. And so this is a very interesting aspect of the Gleason system, and in a way, it encapsulates some of the heterogeneity that we know that tumors have, that maybe some of the grading systems in other tumors don't encapsulate. As I've said, it's a very powerful prognostic for outcome, cancer recurrence, local recurrence, metastasis, and prostate cancer specific death. Powerful predictor that helps guide risk stratification of patients for treatment. It's been adopted worldwide and recommended for use by WHO, but it's over 50 years old. And there's been an evolution in the clinical practice. Tumors are presenting differently. Their earlier presentation, of course, with increased use of PSA screening. Biopsy sampling has changed. And there are obviously new and different treatments that were unheard of 50 years ago. But there's also been an evolution in the pathology diagnostic practice. Research on the prognostic impact of various patterns, the Gleason 2 to 4 patterns, original patterns, cribriform patterns, both on the prognostic impact, but also on their reproducibility. Immunohistochemistry for basal cell markers has been a game changer. It's allowed recognition of some of those low-grade, or many of those low-grade tumors to be actually recognized as a benign lesion of adenosis now. And then there's been research, of course, on new tumor variants, mucinous tumors, ductal, pseudohyperplastic, and there are others. These were not part of the original system. So the pathology practice has evolved over the years, and it was recognized that an update was needed. And so there have been two major consensus conferences. The first big one was in 2005 and a follow-up in 2014. And these are involving the International Society of Urologic Pathology. And there have been ongoing updates from both the ISUP and a sort of a rival organization, if you like, the Genitourinary Pathology Society. So several areas have been addressed in these updates of the Gleason system, including what we're going to particularly talk about today, the Gleason patterns and the grade group system, but also some rules about how you go about implementing the grading. So if you've been practicing a while, you will recognize one of these pictures, maybe the one on the left, which is the original Gleason diagram, or perhaps one of the two, the middle and the right. And these were produced after each of these consensus conferences. And so you can see here at a glance that there has been an evolution of the Gleason system over the years. And sort of just the gestalt is, as you move from the left to the right, the top three patterns gradually seem to lose the cribriform structures, which tend to have been pushed down into the pattern 4 area. Pattern 4 used to be originally mainly cribriform structures. It's gained some more cribriform structures. There were still some that were allowed in 2005, but all of them now are in the pattern 4. But the pattern 4 has also been expanded by some additional patterns represented by these fused glands here and these poorly formed glands here. Gleason pattern 5 hasn't changed quite as much. It's recognized back then as being very poorly differentiated glands. Remember, these things going from top to bottom and from well differentiated to poorly differentiated. There have been some changes with recognition specifically of comeda necrosis and some other patterns. So what are the consequences of this evolution? Patterns 1 and 2 are no longer in use. Many or most of the 1 + 1 = 2 are now regarded as being adenosis based on the use of basal cell markers. But there are also, these patterns were not really very reproducible. And most importantly, they were not necessarily, if you saw it in biopsy, they were not necessarily indicative of an indolent tumor on prostatectomy. So what's happened is that those that are tumor in 1 and 2 patterns have been subsumed into pattern 3, but pattern 3 has also gone a sort of a purification. It's now regarded as well-formed glands only, and the glands, patterns that have a worse prognostic impact, like cribriform or poorly formed glands, have been moved down to 4. So the consequence of this is that the current 3 + 3 = 6. If it's on a prostatectomy specimen, these are very indolent tumors. The patients are, for the most part, cured. They're very rare to metastasize or kill the patient. But the other consequence then is that this migration of pattern 3 into 4 has led to a great inflation for pattern 4. So it's a larger group now. It's more heterogeneous. And as we'll see with the grade grouping coming into this, then Gleason score 7, or the 3 + 4 and 4 + 3, has become more heterogeneous as a result. Pattern 5 is, say, fewer changes. There are some additional patterns. So the other major proposal from the consensus activity was the proposal of this grade group system, and we will discuss this later as an alternative to the Gleason score. Overall, there's better concordance between the biopsy grade and the prostatectomy grade with the new system, better inter-observer concordance, and better prognostic and predictive information from this. So just as a concrete example, let me show you, this is from one of the papers by Dr. Epstein, showing that these were all cases seen at major centers in the US, seen by excellent urologic pathologists, all diagnosed as pattern 3 before the first consensus conference, and correctly at that time. But now, as you'll recognize from the patterns, we have a cribriform, really pretty good cribriform structures here on the right. We have glomeruloid structures on the left. We have poorly formed and fused structures. These will all be called pattern 4 now. So that's a good concrete example of this change. So now we have patterns 3, 4, and 5. The recommendation is generally to look at these and assess them at 4 to 10x at relatively low to intermediate power, and then perhaps confirm at 20x, but not really to jump to 40x too quickly, because you'll overcall a higher grade, potentially overcall a higher grade pattern. And we'll see some examples of that in a minute. Remember, for grading architectural features only, and I haven't said, this is all predicated on the fact that you've made the initial diagnosis of carcinoma, right? And that initial diagnosis of carcinoma will use architectural and cytologic features. It may also use immunohistochemical stains for basal cells and for racemase, MACR, possibly as well. But the grading doesn't. The grading is back to the H&E and the architecture only. So let's talk a little bit about the patterns. I know you're very interested in the higher grade tumors, but it's very important to recognize what is not the higher grade tumor so you can do the appropriate grading. So the sort of thing to remember about pattern 3, it's well-formed glands, single, separate, discrete glands, surrounded by a little bit of some stroma. There may be more, there may be less. Well-formed lumens, complete circumference of cells forming the lumen. Epstein says, if you can mentally draw a little circle around these well-formed glands, then it's pattern 3. So we can see some size variation, we can see some density variation. So if they're very packed, dense together, you might wonder about whether they're fused and then in fact pattern 4, but you need to look at a little higher power then and see if you can see if there's stroma around each of them. One of the things that has been recognized, and if you go back and look at those diagrams again, is that there are some V and Y shapes that are allowed. I mean, these are not spheres, they're tubules, and tubules can branch and have Y or V-shaped structures, and that's still consistent with pattern 3, just as long as you don't think that it's cribriform or fused glands. One difficult area is the possibility of, excuse me, admixed tangentially sectioned glands, which you can see, and these can appear poorly formed, and then you could overcall the next grade up. And the same thing is true for pattern 4 and pattern 5. And I'll show you one example of those. And that's a judgment call that you have to make with experience. That's another reason why one shouldn't jump immediately to high power, because then one is going to be tempted to overcall those areas. So let's just look at a couple of pictures here. So here we have some discrete well-formed glands A nice example of pattern 3. You can draw a little circle around each one of them. There's a little bit of variation in size and shape. And here are some examples of the kind of branching that you might have. This is sort of a little Y-shaped or V-shaped gland here. You can see a little bit more branching here. This is not a fusion. This is not a poorly formed gland. It's consistent with pattern 3. You can also see size variation. So even very small glands, if they have a well-formed lumen, are pattern 3. But you can see there is quite a degree of size variation across this field. You can also see some big cystic dilated glands, maybe even bigger than this. The other thing you can see here is you can have some other types of cytology here in the form of an atrophic gland. So you can see some atrophic features as well. So this is this is the difficulty that I'm talking about. Here we have a focus of what looks to me like nice pattern 3 with well-formed glands. But then you wonder about some areas here and perhaps over here where you don't see the lumina quite as well. And you wonder, are these poorly formed glands, which would put it into a 4. But then you have to sort of step back and say, is it likely that these are tangential sectioning of these glands? If you were to cut in this plane here, would you see something like this? And the answer to me is no, these are not poorly formed glands. They're most likely tangentially sectioned grade 3, pattern 3 glands. But this is a judgment call that you will get with experience. So moving on to pattern 4, number of different patterns that we've seen in the diagram. Cribriform glands, where you have an expansile area of tumor without intervening stroma and with lumens punched out within these areas. Remember, cribriform is sieve-like, is the derivation of that word. Poorly formed glands, which are small discrete glands with rare or no lumens. We've sort of talked a little bit about them already. Or abortive glands, and we want to exclude the tangential sectioning as a possibility there. Fused glands, where you have, glands with decent lumen formation, but they appear to be fused together. These are often, poorly formed and fused glands are often seen together. Glomeruloid glands, that's one of the sort of new patterns that's been recognized as a pattern 4 since these consensus conferences. And you have a dilated cancer gland with a cribriform structure that pouches into the gland and has a single point of attachment. One pattern that isn't typically regarded as one of the pattern 4 patterns, I guess, is that of papillary architecture, and that's particular to ductal adenocarcinoma. Ductal adenocarcinoma can have a number of different patterns, cribriform, which will by definition be 4, but papillary ductal is also scored as a pattern 4. And in fact, if it has comedian necrosis associated with it, it would be a pattern 5. Let me just show you a couple of examples of these patterns. So here we have a nice example of invasive cribriform carcinoma. Really, most of this slide shows you these expansile nests of tumor, no stroma within them, little punched out lumina. It's a nice example of a cribriform pattern. Here's another one. You might wonder, is this some fused glands or is this cribriform? I don't think we have stroma in between these. I think we have a structure here that is composed of tumor with nice well-formed glands within it. Another example of cribriform. Here we have some poorly formed glands. All right, there are a few that around the edges that have lumens, but look in the middle here. You can see they're discrete. They look like little glands, but they don't really have a well-formed lumen. So this is an example of poorly formed glands. Here's another example. Now we're starting to see perhaps a little bit of fusion. So we have a mixture of fusion of glands and poorly formed glands. I don't have a really good example of a pure fused set of glands in one field. Maybe we could argue down here we have that, but definitely we have fused and poorly formed glands up here and perhaps some fusion of better formed glands here, but this would all be pattern 4. One final example of, you can see it's hard to draw. What do I mean by fused? It's hard to draw a little circle around any one of these glands. They appear to be fused together and they're poorly formed as well. You can't see lumens so well. Here's the glomerulation or the glomeruloid gland. Probably best seen here in this one and this one here, where you have a cancer gland, a cribriform structure pouching in with attachment at one point, a bit like a kidney glomerulus. That's where it got its name.
Dr. Barrett, so
yes.
We need to round up. I'm sorry. We need like 2 minutes to go.
Okay. So this is the issue we have with the tangential sectioning of some, I would say, poorly formed glands. You know, we have in the middle here, are these single cells, are these cords? And these are, you know, I think in this case, I would argue this is tangential sectioning of a pattern 4 rather than pattern 5. But let's move on and talk about pattern 5. So this, the guideline here is it lacks glandular differentiation completely. There's little to no glandular differentiation, solid sheets, cords, single cells, small cylinders, solid nests, and some nests with rosette-like areas. The other thing is comeda necrosis seen in the context of cribriform or solid nests. And we need a proper definition of this. You need to see intraluminal necrotic cells or karyarexis. So single cells and maybe little cords, solid sheets, solid nests. These are bigger than the typical kind of glands you would see and they appear solid. Cribriform with proper comeda necrosis here. Cribriform with proper comeda necrosis here. And then a couple of these new patterns, little small cylinder-like structures that have no really good lumen. And then on this, a difficult one here, I think, a nest with something that looks like it could be cribriform, but it's not really forming good glandular structures. I'm going to just, we're very limited on time. I was going to just refer you, there are various rules for grading that have been changed from the original. One thing I want to mention is we want to report pattern 4 in biopsies with 3-4 and 4-3. That carries additional prognostic information. The other emerging recommendation is to note the presence of absence of cribriform pattern 4 in biopsies and prostatectomies, because cribriform is the pattern 4 that has the worst prognosis. There are variants. This is an important thing to mention. There are variant histologies, but we like mucinous, for example, but we grade them according to the same general principles: well-formed glands, cribriform, poorly formed glands versus no glandular. There is one important thing to remember, though. Do not grade small cell carcinoma of the prostate. You would think it is not going to show glandular, so you might say, well, it should be pattern 5, or 5 plus 5 equals 10. But in fact, that would be incorrect. It is a very different treatment of the usual high-grade adenocarcinoma requiring platinum-based chemotherapy and so on. So we do not supposed to grade small cell carcinoma. I know I have to finish up here soon. I just want to say that the final thing that was proposed and has been sort of confirmed is the idea of putting the Gleason scores together into grade groups. So the Gleason grading system, if you look at the combinatorics, even with 3 patterns, there are too many. There's 9 possibilities for grading. What we want is the fewest number of groups, each having a unique prognosis. And based on this kind of data here, this is the 5-year biochemical free recurrence survival for these. You can see the low grades have a very good prognosis. 3, 4 are different, and 8 and 9 and 10 are very different as well. So it's incorrect to lump these together. And this is what's behind the idea of combining these groups together in the lowest number of groupings that have a unique prognostic implication. Okay. And this has been confirmed. Here's showing some nice separation on these Kaplan-Meier curves here for biochemical free survival after prostatectomy or radiation. And you can see the hazard ratios in terms of the risk relative to the lowest grade, 3 plus 3. 3, 4 is twice the risk of recurrence, 5 times 4, 3. So those are different. 8 times the risk for grade group 4, and 9 and 10, 11. So very nice separation here of this prognostic information. And this has been confirmed on a number of other studies here on patients who were not treated. And this is actually prostate cancer specific mortality, which would be a better outcome to measure than biochemical recurrence. And so let me just finish by saying that the grade groups is data-driven. It was proposed on that initial set of data I showed you, and it condenses the grading system to the smallest number of groups, each with the unique prognosis. It starts at the right place. It starts where 3 equals 6 is the lowest that we diagnose now. That should start at grade group 1, right? Not 6 out of 10, but grade group 1. And it correctly distinguishes 7. People have conflated 7 together, but really 3-4 is quite different from 4-3. People have, for clinical purposes, have conflated 8, 9, and 10 together. Really, these should be separated as well, because 9, 10 has a far worse prognosis than 8, significantly worse prognosis. And
Thank you, Dr. Barry. Thank you very much. Sorry, I have to stop because we have very little time for discussion.
Okay, great. I'm on 25 minutes, which I think is what we
Okay, thank you. Can we go to our host? Do we have questions, please?
Thank you very much. We have no questions on our end.
We have no questions on our end. Very good. That's helpful. I do hope that people who are logged on followed quite closely what was presented. I just can start with Dr. Barry and just ask you a question about, you know, the old time feeling that once you found what looked like a vacuole in the cell, are you likely to be considering that there's some differentiation enough to take it to 4 rather than 5? What's your opinion on that?
So the approach, you know, this is a bit like the there's a couple of scenarios where vacuolization would be one. The presence of mucinous fibroplasia or collagenous micronodules will be another. And this is similar to what we were talking about with how do you grade the variant histologies? You kind of go back to first principles, but with vacuoles and with mucinous fibroplasia, what we're supposed to do is subtract away those and see what is in the underlying. Once you subtract it away, I mean, it is difficult, right? Because a vacuole versus a lumen. But if you really think it's a cytoplasmic vacuole, the idea is subtract that away. Sometimes you can have pattern 3 that have vacuole. I've seen that. And certainly 4 and 5 even you can. So subtract that away. And if you're left with an underlying architecture that meets the criteria for cribriform, then it's going to be 4. That's going to be difficult, picking apart true lumina from vacuoles. But what you're talking about in particular is if you subtract it away and you're left with single cells or you're left with sheets or any of those patterns that are consistent with 5, I would call it a pattern 5.
I have a question for Dr. Belizy.
Right.
Dr. Belizy, what is the interest of testing for TILs in colon cancer?
Sure. I had considered discussing this topic. Tumor infiltrating lymphocytes are significant, and they're related to. They correlate with the molecular genetic underpinnings of disease, and I had mentioned that there are these 2 dominant colon cancers. There's the microsatellite stable cancers that are chromosomally unstable and aneuploid, and they tend to be immune cell excluded and don't respond to checkpoint inhibitor therapy. And tumors that are MSI high, these hypermutable cancers, they produce tens of thousands of tumor-associated neoantigens that are incredibly immunogenic, and thus those MSI high tumors tend to be flooded with tumor-infiltrating lymphocytes. And then that's the setup that makes them so responsive to the checkpoint inhibitor therapy, because you've got a tumor that's highly immunogenic, you've got the immune cells that are sitting in the tumor, but they're suppressed to some extent, and then you put on the checkpoint inhibitor therapy, and it turns those T cells that have infiltrated the tumor back on, and you see these really dramatic 50% radiologic response, 20% complete response, 70% rate of disease control, and a durable disease control. So that's one significant. Like, you can look at the histology of a tumor, and if you see a lot of tumor infiltrating lymphocytes, you could predict that a tumor might be MSI high. And we used to actually use histologic assessment to decide whether to do MSI testing or not. And now we've sort of flexed to doing it on all cancers. There's also biomarker testing that you can do. I talked briefly about this dilemma of what to do with patients with stage 2 colon cancer, because they don't obviously respond as a whole to adjuvant therapy, but 25% of the patients recur. And when they recur, they usually die of colon cancer. So there are multi-institutional, developed in tens of thousands of cases, lots of bioinformatics and great follow-up data. So there's this thing called a immunoscore that you can send on a case, and it predicts all kinds of things. It predicts response to therapy. It predicts response, likelihood of response to neoadjuvant therapy. And it is based on the CD3 positive tumor infiltrating lymphocytes and the CD8 positive tumor infiltrating lymphocytes in the substance of the tumor and also at the leading edge of the tumor. Thank you for asking.
Thank you.
Okay, thank you very much. In the absence of any further questions, all I would like to do is to close the session. We started the day with 2 very informative sessions educational session on cancer genomics, and ended up with this very important session on cancer pathology and biomarkers. And I would also just like to remind the participants that they can view the pre-recorded oral presentations, and they're welcome to go to the app to view these pre-recorded sessions. And I would like to thank especially the facilitators for today's sessions, this morning and this afternoon, for the excellent way in which they've conducted these sessions, and also all the participants for their very active participation in the conference. And I look forward to welcome you all back tomorrow morning at 10 o'clock. Thank you very much and enjoy the evening, in South Africa at least.